Good evening, everybody. Today's topic is slightly unconventional, a slightly difficult topic. I hope I'm able to do justice in the time given. It's about the management of Verruco-papillary lesions of the oral cavity. This will be the broad layout of my talk. First, as I said, we need to understand the terminologies, and there are a lot of them which are very confusing, some clinical, some pathological, some clinico-pathological. So we need to really get into the bottom of these terminologies and try to understand them so that everybody is in a single page. The other thing is, of course, the terminologies are varying and differing. And now, of course, we have the terminology of oral potentially malignant disorders. Previously, it was pre-malignant lesions or pre-malignant conditions. And now, of course, there is a unifying terminology called as oral potential malignant disorders. Subsequently, we will also go into what is important about the biopsy implications, little bit about the histopathology we need to know. And of course, there is room for surgical management, definitely. And I will talk about a technique that we have sort of used very successfully, the modified submental flap in these cases. So this would be the broad layout of my talk. Just to keep things in perspective, to understand the Verruco-papillary lesions, we need to basically understand the spectrum of potentially malignant disorders. And I will just breeze through these. The common terminologies or the common potentially malignant disorders are the Leukoplakia, Erythroleukoplakia, and submucous fibrosis. But primarily, I think the Leukoplakia and Erythroleukoplakia are primarily clinical terms, and they don't have specific histological connotations. And this is something that we must understand well. In terms of Leukoplakia, again, there are very many terminologies, differences, classifications, like homogeneous, non-homogeneous. Erythroleukoplakia is classified as speckled, granular, or nodular. We have an entity called as a verrucous-leukoplakia, and the Verruco-papillary lesions of the oral cavity is a spin-off from the verrucous-leukoplakia. There are also two other terminologies that are more commonly used. One is the PVL, that is the proliferative verrucous leukoplakia. One must understand that it is only a clinical term and does not have any pathological connotation, exactly like what leukoplakia and erythroplakia is about. And there is another term called keratosis, which we clinicians keep using commonly in our clinical day-to-day practice. But we must understand that the term keratosis actually pertains to histopathology and has nothing to do with clinical. So there are a lot of terminologies that we tend to use loosely, some clinical, some histopathological in common day-to-day practice. And for example, this is a classical lesion of frictional keratosis, as a lot of people would call. But then there are certain authors to say that, rather using the term frictional keratosis, we tend to use, or they recommend the usage of the term frictional lesions. Similarly, there is a terminology called proliferative verrucous leukoplakia. And again, as I said, that this terminology has no pathological connotation. It just has a clinical connotation. I will come to some of the clinical pictures later, so to put things in slightly better perspective. PVL was described initially in 1985 as an aggressive form of oral leukoplakia. And the importance of PVL is that it has a very high degree of malignant transformation. In a study that is recently published in the IJMS, we find that close to 31% of the patients with PVL, that is the proliferative verrucous leukoplakias, develop at least one squamous cell carcinomas. And about 68% of them, that is more than close to about 2/3 of these patients, develop 2 or more primary squamous cell carcinomas, and up to 2 to 8 in some patients there were 12 squamous cell carcinomas. So we must understand that PVL is an extreme form of leukoplakia, wherein the ability to transform into malignancy is pretty high, and they do tend to develop recurrent cancers. And very recently, again, one of the studies came out in the pathology journals saying that the malignant transformation rate in PVLs would be as high as 50%, and most of these would be squamous cell carcinomas. Anybody who is really interested in understanding the terminology of oral potentially malignant disorders, I would recommend them to read the systemic review and meta-analysis by Eucas, which was published pretty recently in the Head and Neck. And more importantly, from the clinician's perspective, although we have different terminologies, it is very important for us to understand the rate of malignant transformation for each of these lesions. Put together all the potentially malignant disorders, the rate of malignant transformation would be in the range of just around 8%. This is a table taken from the same article that shows the malignant transformation also cumulatively, as well as malignant transformation every year for various oral potentially malignant lesions, ranging from lichen planus, about which is around 1.45%, to lichenoid lesions around 3%, leukoplakia is around 9%, erythroplakia is 33%, and PVLs, which we were talking, whopping 50%. Submucous fibrosis, which is commonly seen in Southeast Asia and even in large parts of our population as well, a malignant transformation rate of 5%. So keep these numbers at the back of your mind, because if you're going to deal with an oral potentially malignant condition, it's very important for us clinicians to know the risk of malignant transformation so that we can initiate appropriate follow-up protocols for these patients. So this was in a way a build-up to the topic that we are going to discuss today, the Verruco-papillary lesions. And majority of these lesions are leukoplakia. There are some white lesions, but they are not exactly leukoplakia. They are leukoplakia-like lesions. You have a broad definition of this, that it is either a whitish or a pinkish elevated nodule and papillary and with a verrucous surface. So it is not just the color of these nodules, but it is also the presence of a papillary surface or a verrucous surface that makes these lesions as Verruco-papillary lesions, a terminology that was coined by Rosenthal in 1941. Ackerman coined the term verrucous carcinoma. This is a very, very close mimic or of the Verruco-papillary lesions. And we have a new kid in the block called oral verrucous hyperplasia. I hope I've not confused you more, but it is very important for us to, when you come to understand this, to understand the spectrum of the Verruco-papillary lesions. By and large, the etiology of lesions is same as that of traditional oral lesions and oral squamous cell cancers. Smokeless tobacco and areca nut, so very common in Southeast Asia and parts of India as well. Again, to say that, it's not much common in the Europe and West. So if you see the literature on Verruco-papillary lesions, it will be very, very less. Again, if you see the site of predilection of these lesions, more common in the buccal mucosa, of course, it can occur anywhere in the oral cavity. Now, the clinical challenge that we face, as I said, is there is a lack of consensus on terminologies. Everybody uses some terminology. Some people say don't use this terminology. So there are not much of guidelines to that. And as I said, there are a lot of clinical terms and pathological terms that we tend to use loosely. For example, leukoplakia, erythroplakia, and PVLs are all clinical terms, whereas oral verrucous hyperplasias and verrucous carcinomas are all pathological terms. So mind you, when you use this terminology, we must know whether a term is a clinical term or a pathological term for our better understanding. Of course, we need an excellent pathologist, an oral pathologist, or somebody who is really dedicated in oral pathology to understand these lesions for us so that we can initiate appropriate management for these lesions. And as a clinician, it is very important for us to communicate, and I will come to the reason exactly why. Again, from the clinical perspective, it is very important to classify these lesions as benign. That means it's nothing much, nothing fearsome of these lesions. Potentially malignant, and these are the lesions that we must be really careful about. And frankly, malignant lesions, obviously, these are proven squamous cell carcinomas, and we obviously are not going to discuss these lesions much. But the focus of today's talk will be on the potentially malignant lesions, as we must know as to how to go about these lesions. The benign Verruco-papillary lesions are all in the range of papillomas to condylomas, and you can see most of these lesions are related to the human papillomavirus, especially human papillomaviruses 6 and 11. A great majority of the lesions are less than a centimeter, and most of them are benign lesions, and we do not have any great diagnostic difficulty in these lesions. Just a couple of pictures that I borrowed from this textbook, which says the oral lesions, just and finger-like fronds in these lesions, very classical of condylomas and squamous papillomas. And these are some things that we see in day-to-day practice. They are clearly benign. Nothing much needs to be done. If at all, there is any suspicion, you can biopsy these lesions and they will be both diagnostic as well as curative. Again, coming to the more problematic ones, the potentially malignant and the frankly malignant. And we discussed briefly about PVL, that proliferative verrucous leukoplakias. And this is the latest new kid in the block sorts of called oral verrucous hyperplasias, which we see very commonly in our clinical practice, which we may not label as oral verrucous hyperplasias, though. And again, the spectrum of verrucous carcinomas and squamous cell carcinomas, again, differences of papillary versus the conventional type. Now, these are the classical presentations that we would normally see in our clinical practice. You can try to see, and these are frank cancers which you can make a diagnosis at distance. But the Verruco-papillary lesions, a spectrum of, I will show you a couple of pictures how they are. This is taken from the classical consensus report textbook, which says some of these lesions are warty, they are elevated. Some of them can have some amount of keratinization, or they may not have some keratinization. So these are some types of exogenous warty lesions with or without degree of keratinization or whiteness or varying degrees of redness. These are the classical presentations of oral verrucous hyperplasias. They could arise very commonly in the commissure, as seen in one of the patients, with a sort of a horn developing in these lesions. They could have a bilateral presentation as well in these forms, bilateral commissural lesions. Again, they are exuberant, they are exophytic. We don't really know much of the endophytic component unless you clinically examine these lesions. And obviously, so these lesions may not have telltale signs of carcinomas. Typical case presentations, as seen in a couple of our patients: 40-year-old lady, no habits, lesion which is there right from the entire lip to the buccal mucosa. The biopsy says hyperplasia and mild dysplasia. Again, a classical lesion in a 40-year-old gentleman, no habits, large lesion. It looks like a cancer, but you biopsy this lesion a couple of times, you send it to your pathologist. Again, diagnosis comes as oral hyperplasia, oral verrucous hyperplasia, sometimes with moderate dysplasia. And how do you really go about these lesions is the challenge. The oral verrucous hyperplasia terminology is something not new. It was coined right from 1980s itself. It's something, as I said, many people may not actually use the terminology of oral verrucous hyperplasia, although when I show you some of these lesions, you can sort of relate to a lot of these lesions, because a lot of the lesions in your clinical practice will be some of these lesions. And very importantly, these lesions are clinically indistinguishable from verrucous carcinomas. So that distinction is impossible to make on a clinical judgment. So if you see the lesions, it may look like a verrucous carcinoma, or sometimes, very rarely, they have a focus of squamous cell carcinomas also embedded in them. And as I said, they have a very high degree of progression, about 3% rate of malignant transformations. Again, when it comes to verrucous carcinomas, I think it's very important, because these are certain pathological terms. It's very important for us to understand these terminologies well, because understanding the ability of spread of verrucous carcinomas is very important. They are actually low-grade variants of squamous cell carcinomas. And unlike the squamous cell carcinomas, they're very rarely metastasized to the lymph nodes. They would burrow the local region. So you may have some amount of deep skin or soft tissue infiltration. You may not have nodal metastasis, even though they seem to be growing very aggressively. So these lesions are characteristic of verrucous carcinomas. Hardly any distant metastasis. Regional metastasis is extremely rare in these patients. So it's very important to understand the spectrum. Although these lesions clinically look very aggressive, locally aggressive, they don't have regional or distant metastasis. So they are good lesions to operate upfront. Again, as I said, you must make this distinction of oral verrucous hyperplasias with PVL, and as I said, the PVL is not a histopathological term, whereas the oral verrucous hyperplasia is a histopathological term. Now, coming to the evaluation, how do we go about? And the important aspect is the biopsy. There are a couple of aspects of biopsy That is really important for us to understand. So it's very, you may ask, why should I know so much about the pathology or morphology of these lesions? Why can't I just biopsy these lesions and send them? The importance is to where to take the biopsy and how to take the biopsy. So if you have an idea of the clinical, morphological, and to some extent the pathological aspects of these lesions, you will be able to take a good representative biopsy, communicate well with your pathologist, and able to manage your patients well. Obviously, if your biopsy comes as invasive squamous cell carcinoma, then you're good. You know that obviously you're dealing with the invasive cancer and your management will be exactly in lines of a cancer. Supposing it is not a cancer, then what is important for us to understand is the degree of dysplasia. And sometimes, broadly, they are classified as mild, moderate, and severe. We know the severe ones may harbinger some cancers inside too or invasive in them, so they all require excision. A great majority of the moderate dysplasias also may require an excision or a re-excision. But when it comes to mild dysplasias, you may tend to follow up these lesions, provided you have taken a good representative biopsy for these lesions. Again, there are certain diagnostic criteria, and these are pathological criteria. I won't go into too much of the details of this, but there was a consensus report based in 2016, published in 2017, about the diagnosis of what is a oral verrucous hyperplasia and a verrucous carcinoma. And there are some differential diagnoses. This is a broad table. I think it's a little complicated if you're going through this table, but I must tell you a couple of things in this table. A squamous cell papilloma, and that's what is there. Most of them are less than a centimeter. So if the lesion size is more than a centimeter, then you think that is slightly troublesome. Again, if you have some telltale signs of, say, invasion, then they tend to occur more often in malignancies, obviously. If you have a prominent fibrovascular core, and that's what the pathologist says, these are classical signs of squamous cell papillomas. They may not actually be seen. These are classical signs of HPV-related infections. And the third aspect is very important. There is a growth of hypoplastic epithelium into lamina propria when compared to the adjacent normal epithelium. So a diagnosis of a oral verrucous hyperplasia is made by comparing it with the adjacent normal epithelium. So what it means for us is that when you take a biopsy for the lesions, to differentiate them between oral verrucous hyperplasia or verrucous carcinomas, you must include a little bit of the adjacent normal as well. If you give only a punch biopsy, most, like for example, a lot of our lesions are proliferative squamous cell carcinomas, wherein a punch biopsy from an area that is very, very vascular is good enough. But if you're dealing with a verrucous hyperplasia or a verrucous carcinoma, it is very important that you give not only from the affected proliferative tissue, but also give a little bit of the normal tissues as well. And you must give a oriented specimen to the pathologist if your lesion tends to be a little small. So that's the importance of giving a proper representative biopsy along with the adjacent normal in cases of oral potentially malignant disorders. Sometimes, of course, you may use adjunct techniques. You may use some sort of dyes like toluidine blue, Lugol's iodine. You can use some sort of various imaging, autofluorescence techniques, or you could use anything like narrowband imaging to better guide your biopsies. But again, there are hardly any randomized controlled trials or robust evidence to support the use of adjunct techniques. What the brain doesn't know, the eye will not be able to see. So you must sort of know to an extent, like a good visual inspection of these lesions, and you would know where to take a biopsy from these lesions. So again, the bottom line for these lesions, at least when it comes to a biopsy, is that you must take it from a representative area, which is non-necrotic. In case you're suspecting a oral potentially malignant disorders, and especially hyperplasias or verrucous carcinomas, take a little bit of the adjacent normal, because that will help your pathologist to give that distinction and diagnosis. Your pathologist obviously will give you a diagnosis of whether it is a mild, moderate, or severe dysplasias or carcinomas, and you could sort of make your treatment based on that. Again, there was an Indian study of 188 Verruco-papillary lesions, and a lot of them were reclassified into oral verrucous hyperplasia as well. So much to say that the authors believed that the amount of dysplasia in some of these lesions were up to 68%, compelling evidence to say that even oral verrucous hyperplasias, when diagnosed correctly, can be a potential malignant disorder. Again, in some of these patients, you would tend to use an imaging. So right now, I think what we have covered is we have covered the oral potentially malignant disorders, the spectrum of oral potentially malignant disorders, the malignant transformation rates of them, the Verruco-papillary lesions, the differential diagnosis of Verruco-papillary lesions, where and how you need to take a biopsy from these lesions. And if you need, you can do some sort of a cross-sectional imaging that is depending upon the lesion. Now, again, from the surgical perspective, all those things were important for us to put things in perspective. And now, when it comes to the surgical management, all these lesions, in fact, most of the potentially malignant lesions would require surgery, and a lot of them would require surgery and surgery only. There is no role for any other oncological management for these lesions unless they are proven invasive carcinomas, which tend to be locally advanced. So most of them, diagnosis and for treatment, it is surgery and surgery alone. And again, as I said, there is a great deal of overlap between these lesions. Some lesions may look like a oral verrucous hyperplasia, but it could harbinger a verrucous carcinoma or sometimes a squamous cell carcinoma. So it is very important for us to excise these lesions as a potential malignancy and not to sort of do some sort of just an excision biopsy with negligible margins. Because if you get a positive margin or dysplasia in one of the margins, then you may need to go back for these lesions, which you avoid to do. So if you have a diagnosis of any verrucous lesion, be it oral verrucous hyperplasia, verrucous carcinomas, or for that matter, anything, you tend to sort of treat these patients, at least from the local extent of these tumors, as a potential malignancy. So don't sort of stinge on the margins, otherwise your procedure will be incomplete and you may have to go back again to do a more definitive procedure. Again, when it comes to smaller lesions, it's pretty simple. You could use any of the techniques. You could use either a laser or a cold knife to get these lesions out. But again, if the lesions tend to be larger, as was more often seen in our clinical presentations, then you may have to sort of size these lesions pretty widely, giving at least a 5 millimeter margin. And as I said, a lot of these lesions tend to occur in the buccal mucosa. So if you give a good margin in the buccal mucosa, then more often than not, you require some sort of reconstruction for these patients. And based on the reconstruction ladder, you have various amount of techniques: the split skin graft, the Loco-regional flaps, and the free flaps. A lot of free flaps and the microvascular flaps, and a lot of emphasis is being given to microvascular flaps in the present era, considering that many people are doing these lesions, and they give excellent cosmetic results. Having said that, it all depends on the setup where you're practicing and the case load where you're practicing. It may not always be possible to sort of, if you are having a heavy caseload in a community setup, to do free flaps, although it is ideal. So you must sort of think about some other options as well. So it's very important from the surgical perspective to keep all the surgical options in your armamentarium so that you can sort of select the best option for some of your patients. Again, the best form of reconstruction is to sort of reconstruct like for like. If skin is lost, you replace skin. If bone is lost, replace bone. If muscle is lost, you replace muscle. And of course, you also ask the patients, your factors of reconstruction will also determine upon a lot of these things about the comorbidities of the patient. If it's a pretty elderly patient, then you may think twice before embarking on a microvascular reconstruction. Also, if the smoking atherosclerotic vessels, you must be a little careful when you're doing microvascular. And of course, it all depends upon the technical expertise of you and your team, and also the patient's wishes. With regards to skin graft, and I told you a lot of these lesions tend to occur in the buccal mucosa, it's a reasonably good option for small lesions. Of course, Sometimes if you use a laser, you may not even require to do any sort of reconstruction for these patients because they heal very good because the laser healing is very good, and you could use either of the lasers, the carbon dioxide or the KTP or any other laser that you want. But if it's fairly moderate, more than that, then you may want to use a skin graft as we had done in these patients. But the problem of skin graft is that there is a tendency, especially in the oral cavity, to have either a partial or a complete loss of this. And when that happens, especially in buccal mucosal lesions, the patients tend to get very bad process post-surgically, that is post-surgically on follow-up, and it will be a very, very bothersome, and especially if the patients are tobacco users, smokeless tobacco users, already having some sort of submucous fibrosis, to have a lost skin graft in these areas of buccal mucosa can be very, very troublesome for these patients. So these are some of the common regional flaps. I'm not going to discuss too much into the flaps. The pectoralis major and the deltopectoral flaps. But suffice to say that, especially for smaller, potentially malignant lesions of the buccal mucosas, predominantly they tend to be bulky and a limited reach. Of course, some of them do tend to reach. Three flaps, I spoke to you about a lot of these. These are the recommended choices, but as I said, it all depends upon the technical expertise of your team and availability of the caseload in your department. Again, the real world option. So we know that skin grafts may not be good, three flaps might be a little cumbersome. There are some regional options, and it's very good from the surgical perspective to know a little bit about the local flaps that we can do into the head and neck. This could be the submental flap, which I will talk to. This is the infrahyoid flap, and something is the platysma flap. So these three flaps are there. I would focus my talk only on the submental flap because we do it in a slightly little unconventional way. I will tell you exactly how we do it. And the beauty of these flaps is that most of these flaps can be done by the team that is excising this. So it's very, very easy. It adds little to the operating time, and I will come to some of the evidences at how exactly we do with a large submental flap. The submental flap, as I said, is the preferred flap, although you can use anything. And as I said, it's just one of our preferences. So I'm just telling you the technique that we tend to follow. Submental flap is something that's not new. It's been there for close to 3 decades. Described initially by Martin. Initially, it was very popular, used quite a lot. It lost popularity, and now it's actually regaining to a great extent. It can not just be used in tumor, it can be used in trauma, facial deformities. You could have a very flexible design. You could use it in an orthograde manner, that is the blood supply from the submental branch of the facial artery, which comes up to 5 to 6 centimeters from the facial trunk. You could use it as a retrograde, that is the blood supply from above, or you could use it as a free flap as well. And again, you could tailor it based on the requirements of these patients. Again, the reach of the submental flap is pretty high. You could use it for classically for the oral cavity and oral pharynx. But again, there have been techniques that have said that you could use it to the nose, palate, neopharynx, and even for cover of temporal bone, lateral parotidectomy defects, as well as spinal defects. Again, there have been some classical modifications, and these are the innovators, the Martin's group. They came across these modifications of flap. You could tend to take the platysma, which is overlying along with the submental flap. You could use the digastric, which is underlying, which we tend to use more often. The anterior belly is taken along with the flap to protect the submental vessels, or an extended flap based on the requirements, or a super extended variation. But the primary concern, at least in oncological circles, with regards to the usage of the submental flap, was its very close proximity to the submental and the submandibular. So some authors felt that inadvertent inclusion of the lymphatic tissues, especially if you're dealing with an N+ neck, could cause a lot of problems. And in some series, there have been recurrences in the range of around 44%. But no major concerns have been reported by many other authors also, who said that you could tend to use these flaps without any oncological compromise. But we are talking about Verruco-papillary lesions, and as I said, a great vast majority of them could be primary cancers or could not be primary cancers as well. So when you're using these lesions, these flaps for the management of Verruco-papillary lesions, per se, there is no diagnosis of invasive carcinoma. So you could possibly use these flaps reasonably safely in that setting. And you can use this flap especially when it is followed by a per-oral excision. Supposing you have to raise a cheek flap to excise this lesion, then there is no point, or it's hardly possible to sort of raise this. Also, although theoretically you still can raise the flap, but it's slightly difficult if the best cosmesis comes when you are trying to excise the lesions perorally. Of course, the other concerns with the classical submental flap was its vascularity, because it's based on the classical antegrade single vessel, and more often for its reach, you have to island the flap. And I briefly described our modified technique, and this was a technique which I published way back in 2013, and we've been using it consistently in our unit. We've done more than 50 odd cases in it. I will just tell you the salient aspects of the submental flap, and this is very important for the reason that anybody, any surgeon who is excising this lesion can, in the very same setting, do it, and it just adds about an hour extra of operative time when compared to other flea flaps, which may take a couple of hours, at least even in seasoned hands. So the important aspect of it is to again to know the landmarks. This is what is called as the antigonial notch of the mandible. This is a very important landmark. Sometimes you mark the flap a couple of centimeters to sort of preserve the marginal mandibular nerve. You do what is called as a pinch test. So because you will have to take this with primary closure. We have done defects up to 8 by 5 centimeters, but our mean size was around 4 by 3 centimeters. So you can take any sort of dimension so that it tends to come in a primary closure. You raise the flap based on the contralateral pedicle. Supposing you're taking it to the left buccal mucosa, then you start raising it from the right side. And again, as I said, 70% of the times the perforator would come deep to the digastric, but at 30% it could be superficial. So tend to include the anterior part of the anterior muscle of the digastric in the flap to be really safe, so that the muscles is safeguarded. This is the raising of the flap. In this case, we had to transpose or tunnel the flap rather to the left buccal mucosa. So we raise the flap from the right hand side based on the submental vessels. And if you have a defect in the buccal mucosa, you tunnel it lateral to the mandible. If you have a defect which is there in the medial aspect, that is in the floor of mouth or tongue, you tunnel it or take it inside the oral cavity in the medial aspect of or medial to the mandible. So that's pretty simple. Based on wherever your defect is, based on wherever your size of the defect, you take the flap and tunnel it accordingly. Again, what our modification was in the classical technique, and I think this picture is there. In the classical technique, what they used to do is, again, this is the facial artery, and the facial artery supplying the flap, and the facial artery, as you know, in the submandibular region, it actually pierces the submandibular gland and goes into the face after exiting outside. So what they used to do in the classical islanded flap was they used to sort of ligate the facial artery at the antigonial notch of the mandible. So what it did was that it gave more mobility to the flap and allowed the flap to rotate well. In our modified technique, what we did was, I sort of know exactly what is the arrow. These are pictures that are taken directly from the publication of ours. We preserve this blood supply. So the blood supply is coming from the submental branch of the facial artery in an antegrade manner, and also perfusing it in the retrograde manner. So effectively, you lift the flap off the bed of the facial artery. So one of the disadvantages of this approach, your arc of rotation is slightly lesser because it is hinged by the antigonial blood supply, the retrograde blood supply here. But then what we found is when we tend to rotate the flap, it tends to come and beautifully sit. For example, in this case, it is right from almost closer to the canine to almost the retromolar trigone. We could able to sort of tunnel the flap to a great extent and reach it out. And as I said, this tunneling was from the lateral aspect of the mandible. If your defect is there somewhere in the floor of mouth or the tongue to a large extent, you could tunnel the flap medial to the mandible and get this reach here. And this is again the lesion that we had taken from our own publication. This was a very large lesion. This was one of the largest cases that we had done. It was involving almost the entire. It was a Verruco-papillary lesion. Again, the biopsy was only hyperplasia. It didn't come as even as squamous cell carcinoma in the final histopathology as well. So what happened was when we resected this, the resection went right from the commissure to the retromolar trigone, and the resection came from here. of course, ideally, you could say that you can do a good microvascular flap, radial artery flap, and reconstruct this defects. I have absolutely no problems with that. But again, what the issue is that you can do something which is slightly lesser and slightly giving the similar results to the microvascular flap. This is the modified submental flap in our case. In the posterior aspect, there was a limited sort of a slight restriction in the reach, but then we could put some amount of fat in that area and cover this area. Again, the advantages of this flap is that it is very thin and axially perfused, very good flap, pretty well perfused, very simple to harvest. And I think this technique is something that anybody can easily master and do it off. If you know the basic principles of the blood supply of the facial artery in relation to the submental vessels, it's something that very easily do. In the classical flap, you island, you actually tie the distal blood supply, and you really need to put a loop at times to sort of dissect the vessels and tend to island. So that is a very tenuous aspect of the flap. But the flap that we described is something of rather very easy for anybody to sort of do it, because it has a dual supply, good vascularity. And when you tunnel the flap inside the oral cavity, the problem is a lot of twisting and turning of the pedicle does happen. So one of the issues in this flaps in gut was what we have faced is quite a lot of venous congestion happens in these flaps. Of course, you could sort of release the flap as long as there is no arterial twist or torsion. You seem to be good. Again, our experience was that the whole procedure was just around 2 hours. This was the median. Of course, in some cases it went longer. The flap exclusive time was around 69 minutes. And a lot of the time is actually gone in tunneling the flap and trying to suture it intraorally, which at times is a little cumbersome. Again, as I said, the mean defect in our thing was 4 to 3. You could go a little higher as well. And this is our series, which in fact our series of close to about more than 50 now, which will come in print in a couple of times. So the biggest advantage of the submental flap is that the donor side gets hidden. So if the patient is actually seeing you, the scar of this surgery would actually lie in the antegonial notch of the mandible, and it could hardly be seen in this patient. For example, this particular patient had the forehead flap, and barring a little dimpling on the left cheek, you can hardly ever make out that he has any cosmetic. So the biggest advantage of this flap is that your donor side morbidity is slightly lesser. Of course, there are certain disadvantages, and the major disadvantages is because it's in the bearded area, and especially in men, you could have hair loss. Supposing you are not giving radiation, as I said, a lot of these cases are done for the Verruco-papillary lesions of the oral cavity. You will not give radiation unless and until it's a proven squamous cell carcinoma, which is T3 or more. Then there is a problem, especially in bearded males, so you must be really careful. But if you tend to do it in elderly women, it gives a good sort of a facelift of sorts in them. As I said, it is very dual blood supply is there in our technique, and even in post-radiation therapy in a couple of cases, we have tend to use the submental flap. So I think I would conclude this talk. We have done a long way here. I have tried to cover the spectrum of Verruco-papillary lesions and the challenges, not just by a diagnostic challenge, but how intelligently you'll have to take your biopsy, how you must talk to your pathologist and get the good diagnosis. You must have this distinction whether it is benign or malignant, and your distinction is very important at that stage. I've told you a lot of useful terminologies. Very important for us to use standardized terminologies, so that it's very important that at least your pathologist and you should be on the same page. So that is very important. And we've talked about proper biopsy techniques, surgical excision with tumor-free margins. And as I said, I've told our technique, and I'm sure that everybody would have their own take. Some people may say, well, I would use a microvascular flap. Yes, by all means, go by it. But then my thing is that we are a very busy unit, and we do take a lot of patients for surgery. So if you have a large number, and as I said, gingival-buccal cancers are sort of in Indian cancers, and of course these lesions are not per se cancers, but they are verrucous lesions that are occurring in the gingival-buccal sulcus. So exactly and as I said, the excision margin is no different for these patients. So you will have to excise the margins, excise these patients the same degree of margins. and you could use any of these techniques. And the modified submental flap at least has worked very well in our thing. And as I said, a lot of anybody can learn this technique, and you may use this technique in your practice. So I would be happy to take any questions or comments, and I will end my talk here. And I hope that I try to do justice and give some perspectives on this difficult topic. Thank you.
Thanks, Arvind, once again for another superb lecture. And I shall open the floor for questions, direct questions to Dr. Arvind Krishnamurthy. If anyone, you can unmute yourself and ask questions, please. I think people are very fond of putting the questions in the chat box as far as you're concerned. All of this they ask directly.
Right.
Yeah, Dr. Rachel Kudabaks, you want to ask a question? Anyone else who wants to ask anything? Yeah, and I think there should be a couple of questions in the chat box, or all thanks or what?
No, there are a couple. I'll probably take them. Some are good evening.
Yeah.
No, yes. The thing is that
but the problem is once you start answering, they'll keep adding more and more.
That's okay. I think no. The issue is a lot of these lectures are not the regular conventional lectures, and right. I actually wanted to give a different flavor in each of these lectures.
I understand, but there's very good audience. But you can start answering the questions in the chat box.
Sure, sir. Yeah, I'm doing that, sir. Somebody has asked a thing about non-surgical treatments. Second, I think good. At least the internet is unstable only after the lecture is over. But anyway, I will try to answer this. As I said, for the benign Verruco-papillary lesions, especially that are there, you could tend to use the non-surgical approaches, and the laser, cold knife, or the cryo, whichever suits you, should be slightly good enough. As I said, one important distinction is to sort of risk stratify your lesions in some way. Smaller the lesions, and again, of course, it also goes by the appearance of these lesions, especially the ones that are less than a centimeter, tend to be benign more often than not, and tend to be related to HPV. In case there is a cosmetic concern in some of these patients, you can use any of the modalities, whichever, a knife, that is a cold knife, a laser, or a cryo to do this. Dr. Madhu Narayana asked, how much margin for verrucous lesions, different role for lymph node dissection? Yeah, as I said, the main issue, Dr. Madhu Narayana, is that a lot of times in a preoperative biopsy, you may not get the actual extent of these lesions. So even it has happened to us as well, that sometimes in post-operative setting, you tend to get a biopsy of squamous cell carcinomas, which is not unusual. So that is the reason why I would recommend to give a margin for these lesions, which is exactly the same as that of a conventional squamous cell carcinoma. And you would be really good for these patients. The other thing is, if there is a verrucous lesion preoperatively, we would not do a lymph node dissection for these patients. Only if it's an invasive squamous cell carcinoma would you tend to do a lymph node dissection for these patients. Yeah, Dr. Manisha asked, would an excision biopsy be better than a punch biopsy, especially for smaller lesions, considering that most lesions are heterogeneous? Yes, I tend to agree very, very much in this. Smaller the lesion, it is preferable to do an excision biopsy and send it. And as I said, in some of these lesions, especially the spectrum of oral verrucous hyperplasias and verrucous carcinomas, you must send some amount of normal tissue as well. So if you are doing a good excision biopsy, I'm sure that you would be sending some normal tissue as well. So the pathologist would be able to make a good diagnosis, and by doing a good excision biopsy, it could be diagnostic and therapeutic for the patient, and especially for smaller lesions, and might have a focus. Yes, again, and as I said, if there is a focus of squamous cell carcinoma in the histopathology, then you must take it at that time. You may have to go back. But as I said, if you are good in your margins, then you may not tend to go back on some of these lesions. So any application of frozen section, very, I think it's Dr. Nilesh, very important. You could do frozen sections because what happens is that if you have a diagnosis of invasive carcinoma on your frozen section, then what happens is you may tend to add a neck dissection, and your plan of reconstruction would change for some of these patients. For example, as I said, like if you are adding a neck dissection, then I'm not too comfortable doing a submental flap for those sort of patients. I would only tend to do a submental flap for patients in whom I know that to a fair degree of certainty, although I can never be 100% certain that there is no lymph node metastasis for sure at least, and and predominantly these lesions could have a spectrum of only verrucous hyperplasia. Yeah, sentinel node. Even in case of invasive squamous cell carcinomas, there is no universal agreement to have a sentinel node biopsies. There is not much of evidence to do it in these lesions unless and until if there is a proven invasive cancer. And again, as I said, some of these lesions are in buccal mucosa. So if there is a sort of a cancer in these patients, and largely what happens is in buccal mucosal cancers, especially if you do address the neck for these patients, like you may want to, unless you want to sort of, so to say, if you are entering the neck, then you do a neck sort of a dissection for some of these patients, but not if it's a short verrucous carcinoma. Without an invasive carcinoma diagnosis, you don't address the neck. The sentinel node biopsy, no, as a routine for these patients unless they are being done as a part of a study or a protocol in your center. So now all white or red lesions in oral regions have a common blanket of oral verruco-papillary lesions, white or red. Again, I think the terminologies are differing. There is a very latest publication that comes in one of the oral maxillofacial journals, saying that the definition of leukoplakia needs to slightly change. So a lot of definitions keep changing, and we must know that the verruco-papillary lesion spectrum, again, as I said, it includes some benign, some potentially malignant, and some sort of malignant. And these are slightly different from your conventional oral potentially malignant disorders like leukoplakia, erythroleukoplakia, or submucous fibrosis. So as you see in some of the pictures that I shown, not all of them actually fit into, they are in a way a non-homogeneous leukoplakia, if you are to say so. But then again, they don't really classically fit because these lesions have a exophytic component. These lesions have some of these lesions may have a slightly endophytic component also, and there is a lot of proliferation activity also. So these lesions are slightly different, and hence the unique term of verruco-papillary lesions. Dr. Anand says, pre-op biopsy suggests verrucous hyperplasia. We undergo surgery, post-op biopsy, verrucous carcinoma. No, generally for verrucous carcinomas, as I said, the involvement of lymph nodes is very unusual. Unless there is a missed focus of squamous cell carcinomas in the histopathology. So if it's come as verrucous carcinomas, you're good. There is no need to add radiation, and there is no need to do a neck dissection. Again, Dr. Manis asks, if you're reconstructing the submental flap, would it make sense to do a prophylactic supraomohyoid neck dissection? Again, it's a very loaded question, and I would say that if there is a suspicion of invasive squamous cell carcinomas, my book, I would not do a submental flap in these patients. So I would tend to use any other flap for these patients. You could, as I said, you could use a platysma infrahyoid or any other flap for these patients or a microvascular flap. So that is my technique. So I sort of don't buy the argument of doing the submental flap in cases of invasive squamous cell carcinoma. Somehow, although there is evidence to suggest, quite a good deal of evidence to suggest oncological safety of doing a submental flap even when the nodes are positive in the neck, but somehow I have not been very comfortable by that approach. Again, if you are good at, if you are comfortable, and there are some centers who regularly practice submental flap even in a proven case of invasive squamous cell carcinomas with the oral cavity. I guess if you are a believer in that approach, you can possibly use it. And make a good tutorial video for this flap. Dr. Victor says, I've actually published this technique, and as I said, there are two publications. One is already done, and one was in 2013. And now, very recently, I think in a couple of days, the other article of our experience actually, including our oncological outcomes, is going to come pretty soon online. So once I saw that, I realized, okay, it's time that I sort of talk about these techniques. So we have a pretty decent experience with this flap, and yes, I could make a video as well. But people who do come to our center to watch us, everybody sort of sees a couple of these procedures. Okay, joint late any neuron of immunohistochemistry cause Dr. Venkata Sarapati. It is you could. There are a lot of. I deliberately didn't sort of touch about this because generally in oral cavity, and that is the beauty of oral cavity. 95% of the diagnosis is pretty much straightforward. It's squamous cell carcinoma. So very rarely I need to really trouble the pathologist in terms of a diagnosis. But yeah, I think there are a lot of other markers that have been used, like for example, K67. There are a lot of other molecular markers that have been tried to be used in the diagnosis of oral potentially malignant disorders, as well as in some other rare variants of squamous cell carcinomas. But then I think a lot of them are in various modes of evolution, and none of them are really good in clinical practice. What I would say. Priya says good. Thank you. Share the video of the presentation. Somebody asked, it's already in Facebook Live, and I'm sure that sir will put it in YouTube, please. Yeah, I think I'm done with the questions.
Yeah, any more? Dr. Suman, you want to ask a question? Dr. Suman?
No, sir.
Any other questions from the audience before we close the session?
No, I would.
Yeah, Dr. Lavanya. Dr. Lavanya, what is your question? You can unmute and ask question. Dr. Lavanya, do you have a question? No questions.
No, this was yes, sir. Yeah, I would sort of tell everybody. I think there are a lot of these local techniques, and I'm sure that you all should sort of if you are good at microvascular, or if you have a good microvascular surgeon in your team, you're good. I think absolutely no issues. But if you're working in a community center, which is which is not, then some of these flaps are pretty useful. I think I'm not telling do this my technique only. Do any technique that you're good enough. If you want to do the infrahyoid, if you want to do the platysmal, if you want to do the temporal flaps, any of the techniques is slightly good. So you can use one of these techniques. Anyway, thank you, Dr. Pacha, once again.
Thank you once again, and we'll see you again next week with another interesting topic. Thank you so much.
Thank you, sir.